Okay, so let's talk about tuberous sclerosis complex. Managing it can feel, well, a little overwhelming, right? Especially with its multi-system nature. But the good news is the latest international guidelines give us a really clear roadmap. So in the next few minutes, we're going to distill those protocols into an actionable guide you can start using in your practice, like tomorrow.
So picture this. A patient walks into your clinic. You see the classic cutaneous signs of TSC, maybe some facial angiofibromas, a shagreen patch. You've just made a critical, potentially life-changing observation. But the big question is, what comes next? That initial finding kicks off a whole cascade of care, and following the right evidence-based pathway from day one is absolutely essential.
At its core, tuberous sclerosis complex, or TSC, is a multi-system genetic disorder. And that phrase, multi-system, is everything here. While the skin findings are often the very first clue, TSC can impact the brain, the kidneys, the heart, eyes, and lungs. A fragmented approach is just plain dangerous, which is exactly why these standardized protocols are so critical. So once you either suspect or have confirmed TSC, the very first step is to establish a complete picture of that patient's health. And this isn't just about confirming the diagnosis, it's about creating a comprehensive baseline that we're going to measure all future changes against. And I really want to stress this head-to-toe evaluation is so much more than a checklist. Think of it like you're creating a detailed map of the patient's disease burden right at the moment of diagnosis. This map is going to guide not only the immediate treatment decisions, but also their personalized surveillance plan for years, even decades to come. All right, first stop, the central nervous system. A brain MRI is non-negotiable. We need to look for tubers, nodules, and especially those subependymal giant cell astrocytomas, or SEGAs, which can get really serious if they grow and block cerebrospinal fluid flow. Next up, a baseline EEG and electroencephalogram to screen for any seizure activity, even subclinical stuff. And finally, a dilated fundoscopy is essential to check for retinal hamartomas. Okay, moving on from the brain, let's assess the core systems. Cardiac screening kicks off with an ECG, plus an echocardiogram for children to find any rhabdomyomas. For the abdomen, MRI is the gold standard for detecting renal angiomyolipomas. We really favor it over CT or ultrasound because you get such superior detail of the soft tissue without any radiation exposure. And we'll pair this with functional checks, a blood pressure reading and a baseline GFR, or glomerular filtration rate. And the workup really is a multidisciplinary effort. A high-resolution chest CT is recommended for all adult women to screen for something called lymphangioliomyomatosis, or LAM. A thorough dental and skin exam, including using a Woods lamp, is standard. And this next one is so important. A neurodevelopmental evaluation is needed to screen for TAND, that's TSC-associated neuropsychiatric disorders, which affect a huge majority of patients. Finally, of course, we offer genetic testing for confirmation and for family planning. So once that baseline is established, our mission totally shifts. We go from diagnosis to proactive, lifelong surveillance. And the goal here is pretty simple. Catch complications early and intervene before they cause any irreversible damage. Brain surveillance is a perfect example of how this monitoring evolves. After that initial baseline MRI, we're going to repeat the scan every 1 to 3 years, specifically to monitor for any SEGA growth. We keep this up until about age 25. Why? Well, because SEGAs are often hormonally sensitive, and they typically stop growing after puberty and early adulthood, making this the highest risk period we need to watch. You can see here that pretty much every affected system runs on its own surveillance clock. Notice that the most frequent monitoring is for the brain and the kidneys, with MRIs every 1 to 3 years during those highest risk periods. And also, check this out, neuropsychiatric screening for TAND is an annual requirement. That really tells you how profound its impact is on quality of life. Now, being proactive means we are going to find issues that need intervention. So let's pivot and talk about the current treatment strategies, starting with the most serious neurological complication. For a SEGA that's growing or causing symptoms, surgical resection is the first-line therapy. However, MTR inhibitors, these are drugs that target the underlying cellular pathway driving tumor growth in TSC. They have been a powerful alternative. I mean, they're capable of shrinking these tumors without surgery, which is pretty amazing. And the utility of mTOR inhibitors goes way beyond the brain. They're also the first-line therapy for asymptomatic, enlarging renal angiomyolipomas that are over 3 centimeters. Same thing for LAM if it's causing a progressive loss of lung function. Now, in an emergency, say an AML hemorrhage, the go-to procedure is embolization to stop that bleeding fast. And since TSC is genetic, screening first-degree relatives is absolutely vital.
If the family-specific mutation is known, we offer genetic testing. If not, the responsibility really falls back to a good clinical examination. And that's where a careful skin and eye exam by a dermatologist and ophthalmologist becomes the key to diagnosis for the rest of the family. Okay, we've covered a lot of ground, from that initial workup all the way through lifelong surveillance and treatment. So let's try to distill this all down into the most critical, practice-changing takeaways. Here are the core principles. First, TSC management requires a team. You can't do it alone. Second, the goal is proactive care, not reactive care, through standardized surveillance. Third, remember that monitoring schedules are dynamic. They change as the patient gets older. Fourth, never forget that your clinical skin exam is very often the critical first step that gets this whole cascade of care started. And finally, always remember to screen for TAND annually. It is absolutely vital for the patient's quality of life. Ultimately, these aren't just some academic guidelines in a journal. They're a tool to prevent devastating complications and to improve real lives. So the question is, how will you use this structured approach to elevate the care that you provide your patients?